I feel that
Yes.
we have one last point. Do you feel that there will be an increase in mortality by upper GI cancer for the delay of diagnosis, for the delay of chemoradiotherapy, for the delay of surgery? And I'm also interested in what all of you from surgeon perspective feel about this.
So I think I would direct this question to both Professor Noriya Uedo and Professor Ying Chao. I think maybe Noriya can comment from the endoscopist perspective and Ying comment from the surgeon's perspective.
So first of all, probably maybe you know, but our epidemiologists in our hospital published the data of natural history of early gastric cancer. So median time to develop early gastric cancer to advance takes 44 months, mean 3 or 4 years. So I think for early stage cancer, I think almost like a semi-urgent or almost like a elective treatment. So I think early stage cancer, I think we can wait until COVID infection status is settled down. This is my opinion.
Yes, so I think, compared with gastric cancer, esophageal cancer is relatively rapid growing cancer. So, but according to some studies, so for those who receive chemoradiotherapy, already, the waiting period between the surgery, the chemoradiotherapy and surgery, in the past, they always put 6 to 8 weeks. But now there are more and more papers that telling us that if you wait for more than 12 weeks or 16 weeks, there is no difference in patient outcome. So I think for neoadjuvant treated cases, maybe the postpone of surgery for 2 or 3 months, maybe the outcome is not different. And sometimes they find the rate of, pathological complete response is higher when you wait longer. So maybe there's not so bad for neoadjuvant cases, but for salvage cases, maybe there will be some difference. If you detect the recurrence too late, maybe, the surgical curability will be lower because you might not have a good, the circumferential resection margin because of the delay of the diagnosis. And for the ESD, I'm not really sure, maybe Philip, you can tell us. So I think maybe for T1A to T1B, maybe there will be more cases that used to suitable for ESD, maybe become the surgeon's candidate, surgeon's patient. Maybe, I'm not sure, but you do both. So maybe it's all your patients. So maybe you can tell me what's your idea about the early cancers.
Yeah, I think both Professor Inoue and I did esophageal and also esophageal ESD. So for me, we have been also providing limited service, but because our number is not very big, so our hospital resource is not overwhelmed yet, luckily. So we have reduced our service, and at one point up to only emergency endoscopy. But right now we are doing 50% of the normal capacity of endoscopy because these few days number of COVID cases single digit, so 4-3 cases per day. So and then for the ESD, we have been actually doing ESD also, but of course I think for squamous esophageal cancer, I think the turnaround time may be quicker. So we try to do esophageal ESD also at our endoscopy unit. So how about Professor Inoue? What's your comment?
Yeah. So regarding surgery, I totally agree with Dr. Chao. His comment is correct, I think. So most of the patients receives a neoadjuvant chemotherapy, and then so we can wait 3 months. We can wait 3 months after chemotherapy, neoadjuvant chemotherapy. We can wait, and then during such a 3 months period, this situation improved. I believe, and then after that we can perform surgery more safely. to the patient. And regarding ESD, at this moment, we think T1A or T1B are close to T1A. So such kind of patient, I think it's better to wait 1 month, 2 months, 3 months. Of course, the patient are asymptomatic. So I think it's better to wait. But of course, the gastric cancer, so poorly differentiated, it's another. Significant cell carcinoma, it's another story. But so regular squamous cell cancer patient and the Barrett's, ESD have to wait.